What is the difference between tracheotomy and tracheostomy? What do we mean by tracheotomy and what do we mean by tracheostomy? So very commonly these two terms are used interchangeably, but they are not the same. Tracheotomy means an opening in the trachea. Okay, sometimes, see, for example, we have some disease in the trachea. So we are opening up, we open the trachea, remove the disease or whatever, maybe a foreign body or disease or whatever, and then we close the trachea and we come out. So we have performed a tracheotomy but not a tracheostomy. A tracheostomy is when the trachea is connected to the exterior with the skin and outside. Okay, so that a tube can be placed from outside into the trachea through the soft tissues of the neck. Right. So why do we do a tracheostomy? What are the indications? So next, the most important thing is, what are the indications of tracheostomy? When do we do a tracheostomy? Tell me. Where? Very good. Where?
Yeah, upper respiratory tract.
What do you mean by upper respiratory tract?
From
So between the trachea and nostrils, if there are obstruction anywhere in between.
Okay, so till the level of subglottis, right? Just above the trachea. So any obstruction in this part of the airway, be it can be any disease, any pathology, any foreign body, or it can be anything that is causing obstruction, we can go ahead and perform a tracheostomy. So it's basically a bypass procedure. So we are opening up the trachea and connecting it to the exterior, putting a tube in here so that we are gaining an access to the airway through the trachea, bypassing the upper airway respiratory tract. Okay, so we are putting a tube in here to access the respiratory tract. Okay, so first is obstruction. I understand. So when you are asked the question, what are the indications of tracheostomy? Okay, what will you write? Upper airway obstruction, that she has mentioned. Okay, so now when you are asked in the exam, so you have to give certain points. You have to write down certain points. Like for upper airway obstruction, what are the common causes of upper airway obstruction? So why are we specifically contained up to upper respiratory tract? Because any disease or anything coming to the trachea and we have to bypass it, so we'll have to go farther down, right? Third, this is the tongue, okay, palate, nose, okay. So when you're breathing in, the air is going like this and coming like this to the trachea, right? So this is the level of, this is epiglottis. So this is the level of the vocal cords. So anything in this area that is causing obstruction is an indication of tracheostomy. Okay. So if I tell you, so this patient needs a tracheostomy. A patient has come to the emergency with breathing difficulty. Okay, a very common scenario in day-to-day practice. So when would you think that this is a patient who needs a tracheostomy? See, for example, the patient can have a breathing difficulty for any reason. He can have a nasal polyp, he can have a big tumor in the tongue base, he can have a CL larynx, or he can have, say, bronchial asthma or a COPD or a lung carcinoma with lung collapse, tuberculosis, anything. Would you do a tracheostomy for a tuberculosis patient? Or a CL lung patient having a lung collapse? No, because we won't be able to bypass that. We are putting in a tube here to bypass the upper airway. So any cause in the upper airway, any obstruction in the upper airway is an indication for tracheostomy, right? So this patient with a CL lung doesn't fit for tracheostomy. So what is the symptom or the sign that will tell you that this patient has to go for a tracheostomy? This patient has an upper airway obstruction. Patient may become drowsy or whatever. Hoarseness of voice will not be. It can be a tongue-based tumor. It may not cause any hoarseness of voice. It will cause a hot potato voice, right? Not a hoarseness of voice. So it is typically stridor. Okay. STRIDOR, stridor. Okay. What do you mean by stridor? So stridor is noisy breathing. Okay. So inspiratory stridor is classical of upper airway obstruction. A patient having a তো সব পেয়ে যাই বন্ধুদের থেকে চিন্তা করিস না, তুই লিখবি তো লেখ। So inspiratory stridor is the indication of upper airway obstruction. Why? If there is an upper airway obstruction, when the patient is trying to breathe in, okay, he is creating a negative pressure in the lungs and the air is forced through a narrow space in the upper airway. Okay, so we are hearing a sound. So it's typically like it's like that. So that's an inspiratory stridor. So as we go down the airway, the type of the stridor changes. So if it's an upper airway obstruction, we have an inspiratory sound that we call a stridor. If it is at the level of the vocal, mostly at the level of till the vocal cords, below the vocal cords, if the obstruction is at the level of the subglottis, we have something called a biphasic stridor. So the patient breathes like this. So it's a biphasic stridor. And when we go lower down, it's an expiratory sound like a wheeze. Patient is breathing in fine. So that's an expiratory sound. So you have to understand the difference. The higher up the obstruction is, the more inspiratory the sound is. When we are going lower down the airway, the sound is more expiratory. So a patient coming to the emergency with breathing difficulty and inspiratory sounds or stridor, this patient is a candidate for tracheostomy. A patient coming into the emergency with breathing difficulty and a wheeze or an expiratory sound is not a candidate for tracheostomy. Okay, so this is the most important sign or symptom of tracheostomy, symptom of airway obstruction that needs tracheostomy. Okay, so what are the other reasons that we do a tracheostomy? Breathing difficulty, ধর তিনটা পেশেন্ট এসেছে তোর কাছে, একটা হচ্ছে ব্রিদিং ডিফিকাল্টি উইথ ইন্সপিরেটরি সাউন্ড, এটাকে আমরা স্ট্রাইডার বলি. This patient has an upper respiratory obstruction, so he is fit for a tracheostomy because we are bypassing the upper airway. এবার যখনই সাবগ্লটিস লেভেলে আসছে, so patient with subglottic obstruction, we can still go ahead with the tracheostomy because we are opening the trachea lower down, not at the level of subglottis. তাই তো, subglottis is at the level of cricothyroid membrane or above. So we are going to the trachea proper. So subglottis we can still address, but if it is lower down, like in the lungs, tracheostomy doesn't help because lungs e jodi disease thake, what will you do with the tracheostomy? Doesn't help. So first and the most important indication is stridor or inspiratory sound, that is upper airway obstruction. Second is, which is considered as the absolute indication of tracheostomy, that is prolonged intubation. Prolonged intubation means when for any reason the patient is admitted and intubated with artificial ventilation, okay, any invasive ventilation. After, so there are different opinions. Some books say it's 10 days, some books say it's 12 days, some say 14 days. So 10 days to 2 weeks. Beyond 12 days, ideally you should not keep a endotracheal tube. You should do a tracheostomy. Why? The persistent cuff pressure of the endotracheal tube. So endotracheal tube cuffs are high pressure cuffs. Endotracheal tube মানে জানিস তো, anesthesia সময় যে টিউবটা দেয়, the tube that we use during anesthesia. So they are typically used for short intervals of time, a few hours. Okay, but if we have to intubate a patient and keep the patient intubated for a prolonged period of time for mechanical ventilation, we'll have to change the ET tube, endotracheal tube, and do a tracheostomy. So these two indications you will never forget. These two are the most important indications of tracheostomy. If you tell the examiner these two things, at least I am 100% sure you will secure the pass marks. Any indications coming later on are other indications or relative indications, like for bronchial toileting or bronchial lavage, or sometimes to reduce the dead space, or for weaning from endotracheal tube. Okay, the patient is conscious, cooperative, but whenever you are trying to take the tube out, he is having some difficulty. Maybe he is having a laryngeal edema or something that will gradually settle over time, or sometimes the patient gets used to the mechanical ventilation, so difficult weaning. So every time you cannot take the tube out and put the patient with under muscle relaxant and put the tube in, it's not possible. So we do a tracheostomy, keep the tracheostomy. When the ventilation is required, we give the ventilation through tracheostomy, and when it is not required, we can just remove the ventilation machine. We don't have to put the tube in, because putting an endotracheal tube means it is put through mouth, right? The patient has to be sedated at least. So if you are planning to sedate the patient, you cannot wean the patient. So sometimes for weaning from ventilation, we need to do a tracheostomy. So these are other relative indications. There are multiple other relative indications that you will get in your book. So most important are upper airway obstruction and prolonged intubation. Done? Okay. Now comes, what are the types of tracheostomy? So don't have to write all these things in your book. Nothing new, nothing, some special things if I say, I'll tell you to write. No need to write anything. So what are the types of tracheostomy? So if we say, we can divide tracheostomy, we can classify tracheostomy in different ways. The most commonest is whether it's an emergency tracheostomy or an elective tracheostomy. Elective means, for example, this patient is in prolonged intubation for 10 days. You need to plan a tracheostomy and do it. So that's a elective tracheostomy. Or this patient has come with stridor with severe respiratory stress, the saturation is 70%, say you have to do a tracheostomy ASAP and save the life. So that's an emergency tracheostomy. So based on the timing of the procedure, you can divide it, classify it as either a emergency tracheostomy or a elective tracheostomy or a planned tracheostomy. First, the second way of classification is based on the site of the tracheostomy. Okay, so what are the sites of tracheostomy? It can be a high tracheostomy, it can be a mid tracheostomy, or it can be a low tracheostomy. So now high tracheostomy means when we are involving or taking out the first ring of the tracheal cartilage. Okay, that's a high tracheostomy. Second and third rings are considered to be mid tracheostomies, and anything below that is low tracheostomy. Okay, so you would ask me, sir, when we do a high tracheostomy, when a mid, when a low, I mean, what are the indications? Why do we do a high tracheostomy, mid tracheostomy, or low tracheostomy? So typically for temporary, so we normally always prefer to keep the trachea and the first tracheal ring intact. Why? That gives us support to the trachea, so that the patient doesn't suffer from tracheomalacia or collapse, because cricoid is one complete ring. Tracheal rings are all C-shaped, right? There's posteriorly its membrane. Okay, so if we sacrifice the cricoid, so the shape of the trachea can collapse. So we can have something called a tracheomalacia. So we avoid going that much high up. The highest we go is the first tracheal ring. Okay, but then again, first tracheal ring or high tracheostomies are considered in very specific cases where there is, say for example, in CL larynx patients, when CL larynx patient comes with stridor, okay, and we think that this patient may need a laryngectomy later on, total laryngectomy later on, we prefer to do a high tracheostomy. Why? Because so that when doing a laryngectomy, this can be included in the specimen, so the entire disease can be removed. Otherwise, we will have to do a laryngectomy here and then again remove the tracheostomy from here. So, a lot of things. Okay. Or based on this, I think it's a bit difficult to understand for you guys this thing. Keep it apart. I'll explain it as we go on. Okay, because so mid tracheostomy or low tracheostomy is that suppose we have a disease coming to the subglottis or up to the level of the first tracheal ring. Then you do a low tracheostomy to bypass that. Or you have a thyroid neoplasm that is very bulky and you cannot access the upper trachea or the mid trachea. Then you have to go down and do a lower tracheostomy. So, low tracheostomy indications are these things only. Okay. And what are the other ways? Like based on the incision, we can do a vertical incision or a horizontal incision. Okay. Normally for elective tracheostomy, so people have your senior batch, everyone, I mean I have seen 10-15 papers, everyone have written the other way around, the wrong way. Okay, try to understand this. Normally for elective tracheostomies, we do a horizontal incision. Why? See, the neck lines, the natural neck lines are horizontal, right? So if we do give a horizontal incision, there's more chance, fair chance that it will gradually go away with time. The scar will heal, not leaving behind much of a scar tissue. Okay, the wound will heal properly. Okay. Whereas if we are doing a vertical incision, it is cosmetically poorer because there will be contractures and the patient will probably have a permanent scar. Right. So, if you are doing something elective, something planned, you have enough time. Okay. Would you prefer to give a bad scar? No. We'll try to do something nice so that it doesn't cause much problem to the patient later on. So, we'll prefer to give a horizontal incision. But in emergency situation, what we care about is shortening the time. The faster you can put the tube in, it's better for the patient, right? So, why do we do a vertical incision? Because our strap muscle fibers are vertical, right? So, if you put a vertical incision and directly reach the muscles after the subcutaneous tissue, we reach the strap muscles, we can get the muscle length longer length of muscle and we can easily separate the muscles. So, and another thing is sometimes in case of difficult tracheostomies, it is sometimes very important to trace the trachea may be deviated. Then if the patient is having severe stridor, probably he is having a CL adding, so something like that. Sometimes trachea may be deviated and becomes very difficult to find out the trachea. It is not as easy as you are palpating, like there may be a big mass over here, you are unable to palpate it. Okay, so we do a vertical incision if we have to trace the trachea from the larynx. You follow the larynx and you then come to the trachea. So that is another reason we do a vertical incision in emergency tracheostomies. But in the planned tracheostomies, like I said, you have enough time because the patient is already probably intubated, or you are doing a tracheostomy for some other reason. So you have enough time, the patient is breathing well, stable. Okay, so you do a horizontal incision. Okay, it's not the other way around. Okay, so now you'll understand. I don't think you'll ever forget this. Think about the scar and it's easier for you to remember. Okay, so now comes what are the steps of tracheostomy. Okay, what are the steps of tracheostomy? So, what is the position? So, what do we want while doing a tracheostomy? To get an easy access to the trachea, right? আমাদের উদ্দেশ্যটা কি? What is the highlight? We have to have the trachea come towards us, closer to the skin. Okay, so only way that's possible is having an extension, right? তাতে দুটো জিনিস কি হয়? First is we get a longer length of the trachea, তাই তো? So this normally when we are like sitting like this, see my thyroid cartilage is here. So this Adam's apple that we have in males, it's a thyroid cartilage, right? And this is a suprasternal notch. So this is the normal length I'm having. So when I'm extending, it is increasing. Obviously, more of the trachea comes out of the mediastinum. Okay, so that is one thing. And another thing is when we are extending the neck, the larynx and the trachea, the whole airway apparatus comes forward, is pushed forward. Okay, so it becomes easier to operate. Okay, so the ideal position is neck extended with shoulder rolls, and we prefer to keep the head on a head ring or a pillow with neck support. Okay, so that is the position. So now we are starting the tracheostomy. So like I said, you have to understand whether it's an emergency tracheostomy or elective tracheostomy. Emergency tracheostomy means you are unable to ventilate the patient. That's why it's an emergency. Someone has written emergency tracheostomy under GA. Is it possible? If you can put GA, then the patient is already intubated. And why would you do emergency tracheostomy? বুঝতে পেরেছিস? জিএ দেওয়া আছে মানে কি? জেনারেল অ্যানেস্থেসিয়া মানে কি? টিউব দেওয়া আছে, তাহলে তো এমার্জেন্সিটা কি? এমার্জেন্সি নেই। বুঝতে পেরেছিস? তাহলে এমার্জেন্সি ট্র্যাকিওস্টমি আন্ডার জিএ বলে কিছু হয়। So it's either it's an elective tracheostomy or an emergency tracheostomy. Elective tracheostomy is usually done under general anesthesia, where they can, or maybe general anesthesia and local anesthesia both. I'm coming to that. Emergency tracheostomy means you cannot intubate the patient for some reason. The patient is having a airway loss. Okay, so we have lost the airway and we are unable to ventilate the patient. That's why the patient needs an emergency tracheostomy. So if we need an emergency tracheostomy, we cannot care about putting the patient under general anesthesia and waiting for that time. No. So we'll have to do it under local anesthesia 90% of the times. Very rarely, if the anesthetist is very expert and there is at least some space, we can do a fiber optic intubation and plan for a elective tracheostomy or a semi-emergency kind of tracheostomy. Don't go into that. Okay, if you are asked multiple questions, then only say those things. Otherwise, most of the times for emergency tracheostomy, we put the patient under local anesthesia. So we infiltrate with lidocaine and adrenaline. Okay, how much is the adrenaline?
2%.
2% is the lidocaine, which is the adrenaline.
1:2 lakh.
What?
1:2 lakh.
100,000, ঠিক আছে, 100,000 হয়। Okay, so lidocaine adrenaline we infiltrate in the skin, subcutaneous tissue, okay, and the spaces. Then we plan for the incision. Okay, so first we incise the skin, whether it is a horizontal incision or a vertical incision. First we are incising the skin. Okay, then the subcutaneous tissue. What comes next is the fat. Okay, then we incise the fat. What comes after that? Strap muscle. So what is the first strap muscle to come? Very good. So it's always like, you remember this thing, many of you make mistakes. So the bigger muscles come superficial. It has to. See, first sternothyroid, thyro, and then, so what will come first? Sternohyoid. Understand? তলায় দুটো ভাগে আছে, উপরে একটা কন্টিনিউয়াস আছে। বুঝতে পেরেছিস? It's like this covered by this. ঠিক আছে? তো sternothyroid, thyrohyoid covered by sternohyoid. হয়ে গেল, বোঝার অসুবিধা নেই। The first muscle that will come is sternohyoid. Then what we get? Sternothyroid. So there are two layers of strap muscles. We won't get thyrohyoid here because we are not going above the thyroid cartilage. Okay, so what we do, we don't cut the muscles, we split the muscles. Okay, in tracheostomy we don't cut the strap muscles, we split the muscles. So we are splitting the muscles in the midline. So it is very important while doing a tracheostomy, in every step we keep on palpating the trachea, because in most of the cases of emergency tracheostomy or any other in malignancies or this, there may be shift of the trachea from the midline. So I have seen many people going into the paratracheal region, searching for the trachea, then causing injury to the carotid and the IJV. Okay, so it's very important. From the first step onwards, we always start palpating the. Once we have given the first started separating the strap muscles, we start palpating the trachea, so that we are bang on midline. Our idea is to stay on midline to cause minimum damage to the paratracheal structures. Okay, so now we have separated the strap muscles. What will you get next? Is a gland that comes here, thyroid gland. So what is the mid part of the thyroid gland called? So the isthmus will come at the level of second and third tracheal ring. So most of the time, since we are doing a mid tracheostomy, we'll get the isthmus of the thyroid in our way. So in earlier books it has been written that we divide the isthmus. We normally nowadays never divide the isthmus. We dissect the isthmus and lift it up. Okay, we have a double hook, a blunt double hook, okay, that we hold the isthmus and pull it up, and it also helps in stabilizing the trachea. Okay, because trachea is a mobile structure, it can move laterally. Okay, so we hold the trachea, thyroid isthmus. It's called a blunt cricoid hook. Okay, there can be there can be a single hook or a double hook based on the surgeon's choice. I personally prefer a single hook. Someone may prefer a double hook. That's absolutely fine, whatever it is. So once you have retracted the trachea, what you are getting, that's a retracted the thyroid, you are getting the trachea, right? So you are on the trachea right now. Would you incise the trachea right now? Why?
To remove the cartilage.
So you have to incise the trachea to remove the cartilage, na? There is another layer there. Yeah, that is very important. Why? If we don't separate the pretracheal fascia, we'll end up having a surgical emphysema. There will be seepage of air below the pretracheal fascia, causing a surgical emphysema. So we dissect the pretracheal fascia from the trachea and separate it laterally. Then we have the tracheal cartilage in front of us. So now there are two ways of doing it. Sometimes for pediatric patients, for kids, we do not sacrifice the cartilage. What we do is we just put a incision, we perform a tracheotomy here, separate, we open the trachea like a flap, okay, and then put the tube in. Okay, we use a tracheal dilator to widen the opening and put the tube in. That is good for kids. Why? What are the risks involved? See, there is always a risk. I'll come to the complications, but there is always a risk of having a tube displacement. Take a tube, you have put a tube in. Okay, the patient will move around and the tube may come out. There is always chance of that. So, see, your trachea is like this. We have opened up like this, put the tube in. Now if the tube comes out, it will again close. And once it closes, the strap muscles also will close over it. So the person, the ICU doctor or the ITU doctor, whoever is in charge of the patient, may not be able to put the tube back in and may lose the patient. Right? So the another way is removing a part of the cartilage so that there is a hole in the trachea and putting the tube through that hole. Okay, so that is less risky for tube displacement. What I personally do is something called a Bjork Flap. So, So what, say this is the trachea, okay. So there are two ways of incising, like I said. So you remove a part of the cartilage, right? Okay, what I do is, I don't remove like this, I take it, I incise like this, keeping this end attached, and then this flap it anteriorly and suture it with the skin. So what happens is, even if the tube comes out, you can have a tract already made. You can just put the tube in, no need to worry. It won't go anywhere, it will go into the trachea only. This you don't have to know, I'm just telling you so that you have an interest, you can understand the thing. So either we can remove a part of, or we can take a flap. Some people prefer to take it superiorly, I don't do, because it can fall back and sometimes even close it. Having the flap inferiorly helps me. Okay, so this is called a Bjork's flap, B-J-O-R-K, Bjork's flap. Okay, this is one way of doing it. So the next step is, so after you put the tube in, okay, then we secure the tube.
So if we need, like in the case of children, you said that we don't
Yeah.
make an opening
Yeah.
with this
Yeah.
part.
Yeah.
So why will it come out in that case in the adult case?
Absolutely, no, in children also it can come out. I'm telling you, we don't avoid sacrificing the cartilage, because they have, I mean, they are kids and they are still to grow. So with age the trachea will also grow. So if you remove a part of the cartilage, so there is probability that the patient will have a scar over there post healing, and the tracheal growth may be hampered, leading to some other complications like tracheal stenosis or those things. Okay, so what we do is, it's a very good question, I am happy that you asked. What we do is, after incising the trachea, we suture the, see this is the trachea, we have opened it like this, we suture this end and this end to the skin. And when we are removing of the tube, when the kid is weaned off the ventilation, no further ventilation is required, when we are removing the tracheostomy tube, we suture this too. বুঝলি, এগুলো খুলে দিয়ে এগুলোর সঙ্গে স্কিনের সঙ্গে সেলাই করে দিই। That way we are not removing the cartilage also. But adult a problem হয়, because adult cartilages are very thick, they are much harder, so it's not easy to open up like this and suturing it with the skin. বুঝতে পেরেছিস? But very good question. Okay, so what are the, and then comes what we are discussing, the flap holo. Then we are putting the tube in. Okay, so before putting the tube in, we have to confirm that we are in the trachea. In fact, before incising the trachea, we have to confirm that it is trachea we are on, because if you see a neck, particularly in kids, that when there is not much ossification of the cartilages, it's very soft cartilages, sometimes you can confuse carotid with trachea. And I have not seen, but I've heard people incising on the carotid, thinking that it's a trachea. Okay, so it is very important that you confirm that it is trachea. So what we do, we take a syringe with some normal saline and this needle, we put it in that and we pull out. If it's air coming in, it has to be trachea, right? And if it is blood coming in, it's not trachea, something else. Okay, so after that we are putting the incision and then putting the tube in. Okay, the next thing is inflating the cuff. So normally on the first sitting, when we are doing the tracheostomy, we always put a cuff tube. There are two types of tracheostomy tubes available. One is a cuffed tube, one is a uncuffed tube or a non-cuffed tube. What is a cuffed tube? You have seen endotracheal tubes, right? Anesthesia tube gulo dekhechiস কোনদিন? There is a balloon like thing below. You have seen it or not? দেখিস নি? So make sure your CR calls me next time. I'll bring a tube from the OR. Okay, next SGD এর আগে একটু তোর CR কে আছে? তুই কে আসেনি নাকি? বাবা ডন। আচ্ছা, যাই হোক, কেউ একজন দায়িত্ব নিয়ে আমার কল করিস বা হোয়াটসঅ্যাপ করিস, ঠিক আছে, আমি তাহলে পরের দিন ওটি থেকে ট্রেকিওস্টমি টিউব এনে জিনিসটা বুঝিয়ে দেবো। So it's a balloon like thing that we can inflate or deflate from outside, you know. So what happens is, say this is the trachea and this is the tube end. Okay, so there is a lot of space around the tube, but তুই immediate surgery করেছিস, so there can be bleeding or saliva trickling in through this. The patient is not yet used to a tracheostomy. You have performed a tracheostomy just now, right? So there will be trickling around. So there is a balloon like thing here. If you put air through it, it swells up. So it's extra luminal. মানে টিউবটার যে লুমেনটা আছে তার বাইরে একটা বেলুনের মতো ফোলে, and it obstructs it touches with the tracheal wall and cause a complete cut off from the upper airway. So anything trickling from the upper airway will not be able to go to the lower airway, because টিউবটা তো বাইরের সঙ্গে কানেক্টেড, আর টিউবের চারপাশটা যদি কভার থাকে তাহলে কিছুই আর বাইরে যাবে না। Okay, that is also another indication of tracheostomy, when you have upper airway bleeding or oral bleeding or something uncontrolled that is going into the lower airway causing aspiration. So aspiration is an indication of tracheostomy also, relative indication though, but an indication. Chronic aspiration. Okay, আচ্ছা, তারপরে হচ্ছে নিলাম আমরা টিউব, এবার দিয়ে if it's an elective tracheostomy we have to gradually wean the patient out. What we do is, when we have seen the trachea, we have confirmed its trachea, then we tell the anesthetist to deflate the cuff of the previous endotracheal tube. আগে endotracheal tube তো দেওয়া আছে elective tracheostomy ক্ষেত্রে বলছি। We tell the anesthetist to deflate the cuff. So they say that the cuff is deflated, okay. So then we incise the trachea and we can see the endotracheal tube in. Okay, then we tell them to pull the endotracheal tube gradually out. So একটু একটু করে টিউবটা বার করে, and when it is above my site of opening we tell them to stop. So they keep the tube below the level of vocal cords but above my tracheal opening. Why? So that if any problem happens during myself putting the tube in, if there is any issue, they can again just push the endotracheal tube and start ventilating the patient. So ওরা কি করে, tracheostomy opening আর vocal cord just crossing the vocal cords ওরা টিউবটা রেখে দেয়। এখানে আমরা we are doing the tracheostomy, তারপর আমরা টিউবটা দিয়ে কাফটা ইনফ্লেট করছি। Before inflating the cuff, what we do is we confirm that it is confirming the procedure is done, we have to confirm the tube is in trachea, right? Again, because that is very important. We have to ventilate the patient or we have to give him the airway. So how do we do it? So we normally connect it to the end tidal CO2 monitor. So if it's in the airway, CO2 will come out and we can monitor it in the anesthesia machine. So we call it ETCO2, end tidal CO2, and we see the ETCO2 curve. If you are having positive, so if it's in the esophagus, you will have 1 or 2 ETCO2 curves and then it will flatten out. But if you are in the trachea, definitely will have a continuous ETCO2. So we wait for 2 to 3 ETCO2 curves and then we confirm that okay, this is in position in the trachea. So now we'll suture it in place. We suture, there are flanges on both sides. We suture it with the skin, okay, and secure the tracheostomy, and then we transfer the ventilation from the endotracheal tube to the tracheostomy tube. ঠিক, so this is the procedure. So steps গুলো মোটামুটি বোঝা গেল। কোনো question আছে? Any questions on tracheostomy procedure? Any questions? ঠিক আছে। So next is, what are the complications of tracheostomy? A very commonly asked question, what are the complications of tracheostomy? এদেরকেও কোশ্চেনটা আমরা দিয়েছিলাম তো সিনিয়র ব্যাচকে। Some people were good, most of them were bad as usual. So complications of tracheostomy কি কি হতে পারে? There can be immediate complications or late complications. Immediate complication মানে কি? During the procedure or immediately after the procedure, what complications can happen? First is obviously any vascular injury or injury to major vessels and other nerves যেটা বললাম, you are incising the carotid instead of the trachea or causing injury to the IJV, the internal jugular vein. Okay, so that can cause hemorrhage and bleeding. Okay. Second is, sometimes while doing a tracheostomy, since the patient is having an extended neck, the apical fluid of the lung may come into the neck. Okay, and I have seen people doing this, injuring the pleura, causing a pneumothorax. So pneumothorax is a very important immediate complication of a tracheostomy. Okay. Third is airway loss or a false passage. You have put the tube in, but you have not put it in the right place. It's not going to the trachea. Fourth is injury to the posterior wall of trachea going to the mediastinum. You have put the tube in. You are supposed to put it through the anterior wall and put it inside, right? But when you are putting the tube in, you have accidentally injured the posterior wall and gone into the mediastinum. I have done that. I have done that myself. A very old 86-year-old frail patient, female patient, having a CA lung. We did tracheostomy for some other reason, but the indication was not CA lung. She had multiple other issues as well. So bronchial lavage and all those things were required. So we put the tube in. The EtCO2 was not coming. We took it out again, put the tube in. EtCO2 was still not coming. So after 2 to 3 times of putting in, we could not understand why there was no EtCO2. So we called the Palmo team. So they came in, they did a bronch, and they found that we have wrenched the posterior wall of the trachea and we were going to the mediastinum. So we had to call the thoracic team in. They did a thoracotomy, repaired that. A lot of things happened. So complications can happen like that. Okay, and there is any injury to the thyroid can cause major bleeding. So you have to make sure that you are handling the thyroid with respect, because thyroid is a very vascular structure. The slightest trauma to the thyroid will cause a lot of bleeding. Then we don't want any bleeding in our airway field. So it's a tracheostomy. Okay, so any bleeding will go into the airway if the site is open. Okay. Surgical emphysema, like I said, if you are unable to remove the pretracheal fascia properly, you may end up having surgical emphysema. Okay. Second is, you may have, if there is aspiration of blood or clots, you may have clot formation in the lower airway, causing breathing difficulties. Okay, and unable to ventilate kind of scenario. Then you will have to do a proper suctioning and cleaning of the trachea through a bronchoscopy, guided bronchoscopy. So these are the immediate complications most commonly. What are the another immediate complications written in your book? It's not very common though. It's called apnea. What happens is, see, we have our sensor is hypercapnia more than hypoxemia for breathing, right? You have read physiology তো পড়েছিস, ভুলে গেছিস না? মনে নেই? হ্যাঁ, মুখটা এমন করছে দেখ। হ্যাঁ, so hypercapnia makes us breathe more than hypoxemia. So যখন CO2 concentration বাড়ে, okay, it's a better sensor, okay, than hypoxemia. So what happens is, আমরা যখনই ট্রেকিয়াতে ইনসিশন দিছি, the patient, we are doing an emergency tracheostomy. So the patient is hypercapnic, CO2 বেশি রয়েছে, oxygen কম রয়েছে, because patient is unable to breathe properly for a quite long period of time. So hypercapnia রয়েছে. So এই hypercapniaটায় সে X রয়েছে, CO2 level X. এই X লেভেলে the patient is breathing. এবার তুই সাডেনলি যখন ট্রেকিয়াটা ইনসাইজ করলি, তখন এই যে কালেক্টেড CO2, it will gush out. So suddenly the CO2 level will fall. তখনও কিন্তু অক্সিজেন দিয়ে রিপ্লেসড হয়নি, জাস্ট CO2 লেভেলটা ফল করেছে। এই যে গাশ আউটটা হলো, সাডেনলি CO2 লেভেলটা ফল করে গেল, পেশেন্ট সাডেনলি গোজ ইনটু অ্যাপনিয়া। বিকজ এতক্ষণ ধর নর্মালি ওর X/2 তে রেসপন্ড করা উচিত ছিল, মানে ব্রিথ করা উচিত, কিন্তু এতক্ষণ ধরে ওই হাইপার ক্যাপনেটে অভ্যস্ত হয়ে 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 হি ইজ ব্রিদিং অ্যাট এক্স, নট x/2। এবার ধর যখনই এক্স থেকে কমে গেল, x/2 হয়ে গেল আবার, তখন ইজ আনএবল টু ব্রিথ বিকজ হি হ্যাজ গট ইউজ টু ব্রিদিং অ্যাট এক্স। বুঝতে পেরেছিস? আন্ডারস্ট্যান্ড দ্য থিং? সো you may have an apnea. So apnea is also, when we are doing, so what we do is, while incising the trachea, we make sure we do it gradually.